Thank you, Madam Chair, and thank all of you for being here. I know it's it's been a long day, so you're almost home. Just hang in there. You know, this is a very complex issue. We all understand that, but it's a very important issue. And Ms. Wilkes, I want to thank you for being here today and for your testimony. It's certainly compelling and certainly something we have to work with. Full disclosure, currently I'm the only pharmacist serving in Congress, and I have experienced the wrath, if you will, of the insurance companies. At the same time, I understand where they're coming from, too. And that's what makes it such a complex issue. One of the things that we deal with, and Dr. Zoffran and Dr. Friedman, I'll tell you that we all use the old adage that misery loves company. I'm in misery with you. So, you know, it's tough. I deal with PBMs. And, oh, by the way, what we have in common with PBMs is that they're owned by the insurance companies. So, nevertheless, one of the things that we have in pharmacy, though, is, you know, we have any willing provider. And that is if we're, you know, quite often we're shut out. Patients don't have a choice. If they come to me and I'm at a network or I'm not a member of that network, they can't get the prescription filled under their insurance. They'd have to pay for it out of pocket. But some states have laws that say if you're willing to accept what the insurance company is willing to pay, then you can participate. Well, the insurance companies don't want to do that because then they can't go out and build networks, is what they're telling me, because if anybody's going to accept it, then the companies, the pharmacies that are agreeing to be in that network and bidding to be in that network aren't going to get the volume that they are anticipating. It seems to me like this is just the opposite of what the economics are on why you would not want to be a part of that. Can you help me out, Dr. Zoffran, as far as the economics of how that works when you have the insurance company pay and you add a network like that?
So what I would first say is, again, in our organization, Physicians for Fair Coverage, 90 to 95% of us are in network. We want to be in network. We strive to be in network. We negotiate with insurance companies to be in network. In many instances, the times we're out of network is when it's a patient coming from another state. Or in some instances, we're in network with everybody, but there may be one specific plan or one provider or one carrier that is not really negotiating with us in good faith. Typically, most of them are, and we're in network with all of them. It is in our interest to be in network. The volume, the cost of providing that service, the cost of billing, the timeliness of payment from the insurance carrier, these are all factors that actually strive to make all of us as physicians want to be in network because it's so much easier.
Okay, well, let me ask you, Dr. Friedman, and by the way, yours is somewhat of an unusual circumstance. Yours is kind of an outlier, if you will, because, as you say, you're in Orlando and you got a lot of people coming, but even more so, why we should be addressing it. Can you speak to the economics of it?
Well, I think for all emergency providers, whether you work in Orlando where I work or anywhere else in the country, we want, as Dr. Zoffran has mentioned and I have as well, we want to be a network. We want to take care of patients. I became an emergency physician to take care of patients. I didn't go to medical school to do billing. I frankly didn't think I would ever be in Congress talking about anything like this. We want to take care of the patients, and we would like the back end, the business side, to take care of it as well. In emergency medicine, we have a unique circumstance in that I can't tell the patient what the cost is going to be. I don't even know if they have insurance when I take care of them. So everything happens afterwards. I can't identify the insurance product. Sometimes my billing company doesn't know if they're out of network for a couple of weeks because it is so difficult. I have a United Healthcare card. Nothing against United Healthcare, but all it says on there is what my copay is.
Right.
That's it.
Right. And oh, by the way, United Healthcare owns their own PBM, and they also own their own mail-order pharmacy.
Right. But I don't know where I'm in network with that card.
Right.
And you know, if I'm in D.C., if I try to find a doctor,
sure,
I have no idea.
Well, and thank you for that. And now, before my time's about up, but Mr. Nichols, I have to tell you, out of all due respect, sir, the chair lady asked you a question at the first of this hearing that I thought you tried to dodge. And I will tell you that whereas I respect the Hospital Association, I do think you have more of a responsibility to be a mediator, if you will, between the insurance companies and the providing physicians to try to help them to avoid the the surprise billing that we're seeing. So I think that is a responsibility that I hope that you will take, that y'all take seriously, and I hope that we can count on you to do just that.
Definitely, I know that time's expired, but I would totally agree with that. We do our best to work with the insurers and the physicians.
Well, as I say, I thought you avoided her question, but nevertheless.
I could try
and the
to get
last
it right.
thing is, one thing about the Pallone bill that I do like is that they would let states decide, because we do know that there are states where it's working what they're trying to do. I hear New York is working with arbitration, and I hope that we don't precede that with any legislation that we pass, and I yield back.